Well, I'm afternoon. I don't know if I told you already. I'm currently in Ghana.
Oh, okay.
Yeah,
Nice.
yeah.
That's fine.
Thank you. Yeah, thank you so much for coming on the platform. I'm really excited to hear more about the information and the books that you have written. I really want to thank you, and I appreciate you for coming on the show.
Well, thanks for the opportunity. I'm always happy to talk about my work.
Definitely, definitely. You're doing some major work. For the viewers who may not recognize you, could you let them know who you are and definitely where you're from?
Sure. My name's Jonathan Sadowsky. I'm a historian of psychiatry and mental illness. I'm based at Case Western Reserve University in Cleveland, although I'm originally from New York City.
Wow. Okay. Okay. That's cool. Big shout out to Case. I'm from Cleveland, Ohio, originally. So
Where are you? What part?
yeah, I always lived on the east side. I stayed in the inner city and the Heights area.
I'm in Shaker Heights right now.
Oh, okay. Wow. That's cool. That's cool. Now let me see. I can ask you this. Now, when did you develop this passion for, like you say, mental illness, medicine, psychiatry, and history? Was this something you kind of got into early on in life, or did you get into it later in life?
A lot of it was surprisingly accidental. I went to graduate school initially to study African history. That was my major field. And in my in one of my graduate school courses, one of my instructors assigned a scholarly article about a so-called lunatic asylum in colonial Nyasaland, what's now Malawi. And it was a really interesting article. It raised a lot of interesting questions for me. These were British institutions, but the inmates were largely African. How did they decide across cultural frontiers? How did they decide who should be considered a mad person? Because madness is often considered to be so culturally relative and so specific to different cultures. And the article was really interesting to me, and I thought, wow, somebody should write a book like this, not just a short article. I didn't think at the time it would be me. That summer, I went to Nigeria. I was doing on a pre-dissertation trip. I was sort of searching for a topic to do for my PhD, and I didn't think I would be doing anything having to do with medicine, science, psychiatry. I was interested in urban history, cultural history, the arts. And then one day, an archivist put on my desk a report on the so-called lunatic asylums of colonial Nigeria. I said, okay, that's my topic. This is so interesting. Then I went back to the States where I'm from, and I won a fellowship to study the psychiatric aspects, the science of it, so that I would be fully prepared for that. And ever since then, I've just been completely intrigued by the whole study of how we determine madness, how we treat madness, how we think about madness, and it's become the main subject of my career.
Wow, wow, that's very interesting. And I can ask you, now how long did it take for you to, because you wrote a book about it. So how long did this take?
To do the book. Well, let's see. I guess it really took about 10 years. I mean, because I started it in 1989 and it wasn't published till 1999. But, you know, I, uh, I had, it started as a PhD dissertation and then it had to be revised for publication.
Oh, okay, okay. I definitely understand. That's very interesting, especially like post COVID. You've been hearing more conversations about mental illness and mental health. A lot of people experiencing depression and stress and anxiety. But it seems like at that time, like maybe like you say in the 80s or the 90s, people didn't talk about mental health as much, especially in terms of Africa.
Yeah, well, I have a few comments about what you just said. First of all, actually, in my most recent book, Empire of Depression, which came out in very late 2020, I was doing the final revisions in March of 2020, and the pandemic was just beginning. And and I remember, and I wrote, you know, what is going to, we did a lot was unknown about how the pandemic would play out. But wrote at the time, and I'm glad I did because it turned out to be correct. I said, this will be adding adversity to a lot of people's lives. It may disrupt supply chains, which might influence how whether people can get medications or not. And but in addition to the adversity, which is a risk factor for depression, not everyone who faces great adversity in life gets clinical depression, and many people who have not faced great adversity do, also do face clinical depression. So there's not a one-to-one correspondence, but we do know that the more adversity you experience, the greater your risk for clinical depression. But as I say, it wasn't just the adversity that I was mentioning, it was the isolation. Adversity plus isolation is a perfect recipe for anxiety and depression. And so, I said everything we know from history suggests that as the pandemic progresses, we will be hearing more about depression and anxiety. You're right about people not talking about depression or mental health that much. And I like to think certain things are getting better. I wrote an article for the Washington Post when the Congressman John Fetterman came out and said that he had clinical depression. And I said that in some ways this was promising that a prominent person is willing to admit this publicly, and I think that helps reduce the stigma. But in some ways, this whole question of people talking about it in Africa, it remains very contested issue. A lot of my reading is in Nigeria still, and as far as I can tell, Nigerians are very divided on this issue. For example, on depression, and I start my book on depression by citing a passage in the novelist. Sorry, I'm blanking on her name. She wrote the book Americana and a few other novels based in about Nigeria. Anyway, but in the novel, she describes one of her main protagonists is named Ifemelu, and Ifemelu is in Pennsylvania, in Philadelphia, and very isolated. And she has an aunt who's a doctor, Nigerian, but also living in America. And the aunt says, "Oh, I think you have clinical depression." And Ifemelu says, No, I don't have clinical depression. I have real problems. This is not an issue of mental health issue. And they have this debate, and I use that dialogue between those two characters to illustrate the dilemma. Because Ifemelu believes, oh, this is such an American way of looking at things. You want to put an illness on everything. And you're in Ghana, and I'm sure you could, I bet if you go to a bar this evening and ask people, is depression prevalent in Ghana? I bet you will get a heated debate. I think you will hear some people say, this is my guess, you can take me up on it or not, but my guess is you'll hear some people say, oh yes, of course, it's not talked about enough, it's too stigmatized, and we need to be more open about it. And of course, with all the adversity we face, there's going to be depression. You're going to have other people say, nah, that's a Western thing. This doesn't apply to Ghanaians. And there's a Kenyan journalist that I mentioned in some of my writing who wrote an article about this, and he said, how many African languages actually have a word for clinical depression? He said, and he's in Kenya, of course, where several languages are spoken. He said, probably none. I don't know that settles the issue, because even if there's not a word that perfectly corresponds to clinical depression, there may be clusters of symptoms that resemble what we call clinical depression that are recognized as illness. So it's a complex question.
Yeah, definitely, but very, very thought provoking, very, very interesting. Now I can ask you, did you get a chance to visit any other countries on the continent, or did you just spend most of your time in Nigeria?
I've been to Kenya and I've been to South Africa, but shorter stays, not the long. I was in Nigeria for months and months, over a year.
Oh, okay. Wow, wow. Now you had mentioned the pandemic in March. I was actually in South Africa in 2020. I had got there like in January, and they had the lockdown. So I was in South Africa from like January to October maybe. And like you
Mhm.
say, the isolation, man, it was just too much. It was really affecting people, myself included. If I'm being honest.
Oh, well, it was a hardship for everybody. I mean, I have children. They had to attend school online. We were all cooped up in the house, and then we all got COVID. My whole family got COVID. It ripped through the household. So yeah, it was quite a struggle.
Yeah, definitely, definitely. Okay, now I wanted to ask you about another book that you had wrote about ECT. If you could talk about that a little bit.
Absolutely. Well, ECT, for listeners who don't know, is short for electroconvulsive therapy, sometimes referred to colloquially as shock therapy, although most doctors who provide it don't like that name because they think it creates unnecessary fear. Um, After having done this work on Nigeria, I decided to turn my attention to my own society, the US society that I'm more familiar with, and grew up in. And the reason I got interested in electroconvulsive therapy, I can actually date the actual moment that I got interested in it. I was having a dinner party at my house, and people were talking about this issue of depression. At this time, uh, there was a lot of attention to Prozac, was relatively new. People were talking about Prozac a lot. And then somebody said something about um, electroconvulsive therapy. And everybody at the dinner party was talking about, oh, do they still do that? It's a horrible abuse. That's like torture or human rights violation. And then this one woman at the party, a friend of mine, said, oh, it saved my father's life. And everybody looked and said, really? That's so interesting. And so we asked her, and she said, yeah, he was in a very deep depression, and um, and I think he was suicidal. And I think if it hadn't been for the ECT, he would have killed himself. And this, I was so interested in this. And then as I started reading more and more about it, I started feeling like, how sometimes in science fiction and fantasy books, there'll be like two split realities. People are living in different realities. It seemed like you read some people on the subject and they're talking about this as a horrible form of medical abuse. And you read other people saying, oh, it's the most effective treatment in psychiatry, and it's relatively safe and we should be using it more. So I'm always attracted to ambiguities, and so I decided to do a deep dive into this subject. And what I found is that, in fact, we shouldn't think about it in such a polarized way, and that if you look at the history, it actually has been used as a form of abuse, and it does carry very serious risks. But on the other hand, it is an effective treatment that many people have benefited from. I think that the clinical literature, my own opinion, is that the clinical literature on electroconvulsive therapy understates the risks a bit. And I base that on the number of people who claim to have experienced memory loss from the treatment, which is a very serious side effect. People don't like to lose their memories. It's very hard to settle conclusively because sometimes people with serious mental illness can lose aspects of memory anyway from their illness. And there hasn't been enough long-term study to prove nobody really knows, in my opinion, how common permanent memory loss is from ECT. But it's an adverse effect of the treatment. Everyone agrees there's some risk. It's just the degree of risk that's a matter of debate. And my argument for against people who would say, well, we should ban electroconvulsive therapy, it's inhumane, we shouldn't do it. My argument would be, well, first of all, it should, in the vast majority of cases, only be done voluntarily. I don't think, I mean, there may be certain very small number of exceptions where people should have it involuntarily, but for the most part, it should be done voluntarily. And that, second of all, yes, there are risks of serious side effects, but there are risks of side effects with many illnesses and treatments. We don't give, and that's why we don't give them to healthy people. We don't give chemotherapy that's used for cancer to healthy people. We give it to people who have very serious cancer because that's the only way of getting them better. And they are going to experience adverse effects. And so I guess what I'm saying is that if the depression is serious enough and it hasn't, and other treatments haven't worked, ECT really should be considered. But what I try to do in the book is try to not just document the history, but try to show how it became so polarized, such a highly contested and debated thing. And and I think part of the reason for that is the reality that it was in fact used in abusive ways in a number of settings. Psychiatrists who provide ECT are often very resentful of media representations like the movie One Flew Over the Cuckoo's Nest, because they think this exaggerates the risk, or it makes people afraid of the treatment. And they're right to a certain extent. I do some teaching of psychiatry residents at a local hospital sometimes. And even now, all these years after that movie, they tell me when they mention the possibility of electroconvulsive therapy to their patients, the first thing they think of is One Flew Over the Cuckoo's Nest. But one thing I found was that the depiction of One Flew Over the Cuckoo's Nest, that depiction was not completely implausible. It may not be typical of how ECT is practiced now, but people remember these things. I could go on and on about this, but one other aspect about electroconvulsive therapy that contributes to the stigma of the treatment and makes it so polarized is that it was one of the many forms of conversion therapy used on gay people at a time when gay people were considered to be having an illness. And this is well better known in gay communities than it is outside of them. But that's another reason why people, are understandably wary of the treatment.
Wow, wow. I appreciate you breaking that down. Yeah, One Flew Over the Cuckoo's Nest. That's a definitely a classic movie, man. I'm glad you brought that up.
Well, I've had to watch it many times for for my work. I actually think in some ways it's less about psychiatry than about gender. It's a very misogynist movie in some ways. The evil Nurse Ratched and the way the women in the movie, except for the prostitutes, the women in the movie basically serve to keep men down and don't allow men to experience their full freedom and enjoyment of life, which it's kind of a sexist message in my opinion. The director of the movie actually was from Eastern Europe, and he intended it as a parable about communist totalitarianism. And so it wasn't really about psychiatry to him at all. The psychiatry was just a vehicle. But when I say that it wasn't completely unrealistic, the author of the novel on which the movie is based, Ken Kesey, he had actually spent time working in a mental hospital. So he'd been able to witness some of this. And actually, the representation of electroconvulsive therapy in the book is more ambiguous than the representation in the movie, because in the book, there is a character, a patient, who says, this treatment can be used in abusive ways, but it actually does help people, and people don't understand that. So, it's actually put into the voice of a patient in the book.
Yeah, yeah, media is powerful because that movie came out long before I was born. But like you say, it's people still to this day, when you think of, if they want to go get some type of treatment or help, that would be one of the first things that pop in their mind. They don't want to end up like that. But I can ask you, how, if it's done properly, how is ECT, how is it used on people? Do they have they have to take medicine, or do they have to go through treatments or therapy?
Well, if it's done correctly now, it's what's called modified ECT. They don't really call it that anymore. It was originally called modified ECT when these modifications came out in the 50s and 60s. But basically, you have to do two things to make it safe. You have to put the patient under general anesthesia so they don't experience the pain from the jolts of the electricity. And you also have to give them muscle relaxants, because the curative effect of electroconvulsive therapy is the convulsions. It mimics epileptic seizures. And if you don't have the mimicking of the seizures, you don't get the therapeutic effect. In the early years of the treatment, this was not realized that you could use muscle relaxants. And so people were flailing about, and there was risk of broken bones and so forth. But if it's done properly now, that shouldn't happen. So normally what would happen now is, if you were recommended ECT, you'd get a course maybe twice a week for a few weeks. And if it's, in my opinion, probably best followed up with other treatments. That is, you shouldn't just get your ECT and then just walk out and assume you're fine. But it does bring very, very fast relief to people, including people who have been, you know, desperately ill and for a long time. And this is important to mention because a lot of times some patients have been so depressed for so long that the only reason they're willing to try this treatment that scares them is that they're at a point in life where they feel like, what do I have to lose anyway? I don't myself think it should be a first-line treatment for people, certainly not for people with mild depression. I think it should be really for people with severe depression when other treatments have failed. But I do think patients should be alerted in advance that there is a risk that they will lose memories, because if you're prepared for that and you're willing to take the risk, it makes a big difference than if you don't realize that going in.
Right, definitely, definitely. That's a good point. Let me see. Now, I wanted to ask you more about your book, "The Empire of Depression." You had kind of spoke on it, and to my understanding, it's been translated in 6 languages.
Yes, I was very happy to see the many translations of the book. So far, there's a Spanish, Chinese, Turkish, French, and Russian edition, and the Arabic edition is being produced right now. So that was a great thrill to me to see it being translated into all these languages. And each one has a different cover, which has been fun for me to see how the different covers have come out for the book.
Wow. Okay. Now, is that something that, like, was that your goal? Was that something you anticipated, or is it something that kind of happened? Like, okay, we're going to translate this book to this
No,
language and this language.
I had no idea. I mean, I know sometimes if a work of history is of sufficient interest, you might get one or two foreign translations. If you had told me in advance, you'll get 6 foreign translations of this book, I would have said, oh, no way. That would be too much to ask for, but obviously very pleased by that. So if you'd like me to talk a little bit about the book, I mean, there's a few things that I try to stress in the book. One of the reasons that I was motivated to write it was that I felt that although there was a small historical literature on depression, I felt much of it was very remote from patient experience and the pain and the suffering of depression. And so that was one of my goals, was to try to bring that to the fore and make sure the patient's voice was heard to the extent that we could access it. There are source limitations, but I did my best. And one of the ways in which I felt that some of the previous writers on the subject had been a little bit deaf to patient voices and concerns was that a lot of the historians who've written about depression write very alarmingly about overdiagnosis. So we're giving depression out, diagnoses out like we're giving out pieces of gum, like anyone can get one these days. And I don't deny that there might be a real problem of overdiagnosis, but I'd make a couple of points in response. First of all, before right now, the World Health Organization considers depression to be the leading cause of debility in the world. And people look at that and they look at the skyrocketing numbers of people with depression diagnoses since the 1970s and assume, oh, we must be overdiagnosing. And maybe we are. But I would make a couple of arguments. First of all, in the 1950s, public health experts, psychiatrists thought we had too much undiagnosed depression. So from their point of view, we're only now seeing what was already there. So it's not necessarily obvious to me that we're overdiagnosing. In some ways, we might be doing a little of both. That is, we might be overdiagnosing in those communities that are relatively affluent and have access to healthcare, and underdiagnosing among the poor and less privileged people who actually probably need the treatment the most and who could really benefit from psychotherapy or antidepressants. And but getting back to this distance from patient experience, this is also much of the historical literature is very critical of antidepressants, and I felt there was something very counterintuitive about this. So many people, take them and say they're benefiting from them. Critics say, well, maybe it's all placebo effect. I frankly find that a little implausible. Millions of people are taking this drug all over the world now. Their doctors are observing them. The data from clinical trials are not impressive. I will concede that. They do not perform much better than placebo. I think there may be other reasons for that, which I can get into. It gets a little technical, but I find it so implausible to think all these people are taking these drugs, finding benefit, and it's all placebo. So, it's not that I don't recognize that there might be problems with antidepressants. Just like with ECT, there are adverse effects, but there are costs to every medical treatment. There's almost no medical treatment, especially no medical treatment that's being used very, very commonly. And one last point, I mean, I could probably name others, but last point I'd like to stress from Empire of Depression is one of the real lessons of history to me was to see that we don't really have to choose between biological and psychological and sociological understandings of the causes or the treatments of this. For the last maybe 120 years or so, the field has been split between those who want to focus on mental illness as brain disease and treat it with direct physical interventions like pills or ECT, and those who see them as a result of environmental problems or life event issues, trauma. And those people tend to favor talk therapies, whether it's psychoanalysis or cognitive behavioral therapy. And this is a false choice. There could be a biological cause, and it still could be helped by talk therapy of some kind. There could be a life event cause, an adversity cause, and still be helped by a direct biological intervention. And I think this represents a kind of mind-body dualism that is very deeply rooted in certainly in Western culture. I think it's less deeply in many other cultures. I think, for instance, in most African cultures, it's my belief that mind and body are really not seen as really these separate things that are completely alien from one another. But this is a very, very deep aspect of Western culture, and it's very difficult to dislodge. And like if you go onto social media any day and start looking at debates over depression, you'll see this. You'll see this debate getting enacted over and over again. Oh, it's trauma. We need to treat with talk. Or no, it's a real biological illness. But that's the problem, is the word real. In Western biomedicine, a real illness is one that is often considered to be one that we had no definite physical causes for. But that's a little bit arbitrary. Why does it have to have a known physical cause to be considered an illness?
Yeah, yeah, definitely. You made some major points. Now, you have so many books that's very interesting topics. Have you ever thought about doing maybe like a documentary or anything like that?
Um, I don't know. I've never really thought very hard about it. I was a consultant on a documentary about mental illness a couple of years ago, and had the opportunity last year to write some notes, some historical notes on depression for a play about antidepressants that was being performed in London. So that was kind of fun. One of my current projects is I'm the editor of a massive 6-volume cultural history of madness that's going to be coming out from Bloomsbury Books in 2026. So I've got a lot going on. My sister in Los Angeles is a filmmaker. She doesn't work on documentary films primarily, so maybe I have an in. That could be an interesting thing to maybe try to do a documentary, but it's not something I've really applied myself to.
I was thanking you. I really appreciate that the work that you have done, and I definitely look forward to the work that you have coming in the future.
Thanks very much. And it was a pleasure talking with you, and I'm glad you got what you wanted from it.
Yeah, yeah, definitely, true indeed.